So you asked me to speak about guidelines, and you asked me particularly about the state of play of guidelines, and felt the implication was, why aren't there standard guidelines? So I've kind of put together a selection of different guidelines, this first slide on the utility of guidelines, but also a reflection on sometimes the difficulty in using guidelines. So here we go with the utility. So you can use guidelines to try to standardize treatment. They're a very useful source of education, both for the clinical community, but also have been used. And I know my patients in the UK often do go to the British Society for Haematology guidelines and have a look at them. And in fact, sometimes they print them out and bring them to me and ask me why they say something in particular. And that can be particularly important in the setting of these diseases because they're rare. You know, it's rare for a clinician to have a 42-year-old patient with polycythemia vera. And the field is changing rapidly. And so it's very, very difficult for a haematologist who sees many different diseases and has to manage many different diseases to be completely up to date. Guidelines can also lead to better use of health resource, including testing as well as drugs, may lead to reimbursement, probably helped us, for example, in the UK with reimbursement of ruxolitinib for myelofibrosis, and can sometimes be used for identifying the need for clinical trials, but also for endpoints for clinical trials. And there are many, many guidelines in the setting of myeloproliferative neoplasms. There's a smattering of them here. The British Society for Haematology has reworked its website, and it's now rather large, but it has many different guidelines in the MPN setting. And this, only just yesterday, we were updating these, which include the diagnosis and management of PV, and these are actually the top cited articles in some of our, the British Journal of Haematology for the year they were published and for many years later. And for us, that's a great thing, but it also reflects the fact that people find them useful and want to read them. There are also guidelines that are not just national. So these are the European School of Medical Oncology guidelines for MPN. Here is the algorithm for myelofibrosis. These are written by a panel of European clinicians. Most recently, probably, are the NCCN guidelines, and these are really, really important. So there are a few slides on these because of course, the reach of these guidelines is really rather massive, and the aim of the guidelines is very global. So they are looking at making guidelines for diagnosis, treatment response, disease burden and planning. They already have guidelines for myelofibrosis. They will have guidelines for PV and ET, and then later they will be looking at the more atypical end of the spectrum of myeloproliferative neoplasms, and this is an area where we certainly need guidance. If we can't agree on treating or not treating 42-year-old patients with PV, these are much rarer entities. So the reach of the guidelines will include how to make a diagnosis. This might well disagree, for example, with the WHO diagnostic criteria, and you've probably seen in the medical literature, for example, the British Society guidelines for PV assessed against the WHO guidelines. And that's important. It's healthy debate, but it can be a bit confusing and a little bit difficult. Usually there's no right or wrong answer, but it's just about using something that works for you in the setting in which you're working. In the NCCN guidelines, they endorse the WHO diagnostic criteria, but also are very much promoting the measurement of disease burden using symptom assessment. I think these are the first guidelines to really endorse this fully, and I think the impact and importance of that is very significant. They also can be quite controversial. Here, for example, is the NCCN guideline for the treatment of low-risk myelofibrosis. We could equally have had Rainier and Mary Francis talking about whether you should or should not treat low-risk myelofibrosis. I had to do that with Tiziano Barbui a couple of weeks ago, and it was difficult. But the guidelines are actually quite dogmatic. Decide if your patient's symptomatic or not. If they're asymptomatic, either observe them and put them in a clinical trial. But if they're symptomatic, they give you lots of different potential treatment options. Alternatively, there are also other guidelines. So it's not just Western Europe, the UK and the United States. There are guidelines in Eastern Europe as well. And I'm showing you these guidelines that come from the network known as CHEMPO, which includes much of older Eastern Europe. And there's quite a difference between some of the guidelines that we have. And in fact, this is taken from a slide from one of the key authors of these CHEMPO guidelines, dividing the West and the East. And there are some significant differences here between what would be done and not done for these patients. For example, in Western Europe, we would not treat a young ET patient, platelets less than 1,500, other than perhaps with aspirin. The CHEMPO guidelines, on the other hand, would actually be treating these patients if they had a platelet count of over 600 with either anagrelide, which is definitely not first line in Western Europe, or interferon. So there's quite a diversity in clinical guidelines across the globe. And that's illustrated. I just also wanted to illustrate another issue here. So here is a 45-year-old female diagnosed with ET. Patient is CALR positive, white count is 9, hemoglobin 13, platelets 1,245. What treatment? So, if this patient was being treated by Rainier, Mary Francis, Martin, probably myself, this patient would probably have watch and wait, maybe get aspirin. If they're in Eastern Europe, they would probably get anagrelide or interferon plus aspirin. Here you go. But actually, more recent data, which is more recent than any of our guidelines, comes from a collaboration across Europe looking at retrospective analysis of low-risk patients treated with aspirin or not, and showed that the CALR patients here, treated with aspirin, black, had a higher risk of bleeding, not true for JAK2 positive patients. The CALR patients with regard to venous thrombosis had no benefit of using aspirin, but the JAK2 patients did. So this data is not reflected in any current guidelines and would have influenced the treatment of that patient. So that illustrates the disadvantages of guidelines. They may not be up to date. They may encourage formulaic practice, which is not good. We want to individualize to some extent our practice, and they may not reflect always locally available therapy. We discussed that this morning. Or local practice. For example, there's a lot of discussion in PV about patients living at altitude who might need a higher hematocrit. So what are our current efforts? They're ongoing, and they should always be ongoing. They remain relatively region-specific. I've illustrated quite a few of those for you. But there is collaboration across the EU in the European Leukemia Net, which also includes the United States. I should have made a comment here about patient advocate involvement. I think that's quite variable according to the guidelines. In the UK, we would involve patient advocates, and we have somebody from MPN Voice. I think in the NCCN, they involve patient advocates. But this is really a work in progress, and I think, but I don't know if you agree, that it's valuable to have the advocacy input in terms of guidelines. And I think that's it. Thank you.
Thank you, Claire. Any questions about the state of the guideline development? Yes, please, Rainier.
Maybe a comment. In the Netherlands, we decided that there will be no guideline without patient being involved. So that's just regulation.
Yeah, we also are not allowed in the British Society of Haematology to produce a guideline without patient involvement. But sorry, may I just ask Rainier back a question? How do you involve patients, and how do you find your patient, and how do you prepare them for the process of guideline writing?
Yeah, we use the patient advocacy. It's called Hematon, or the MPN Society regarding MPN guidelines. And it's interesting to see that the questions they raise are completely different from the questions the doctors involved raise. So it really adds to the guidelines, yes.
What sort of things do patients say that you don't hear from doctors?
Especially the impact of the different treatments. You can easily make such a schedule, as we've seen several examples, but what is the impact for the individual patient? Nuances, and we showed that, I think, today, are large nuances, and you really have to discuss with the patients, and I think that's what they ask for. And yeah, what's complicated is, like Claire just alluded to, a 42-year-old patient with PV, hematologists will see one or two, and the question is, what is our solution to that, and should we go to dedicated centers for these patients? What's the role of second opinions? And that's something that should also be in a guideline, in a local guideline. What should we do to get the patient well informed? Yeah.
And do you does your MPN group also publish the local guidelines on their website or link to them?
Yeah, they link to them. Yeah, but we also publish in that journal because we have to interpret the guidelines.
Yeah.
And pick the points of discussion.
I was about to ask Claire whether MPN Voice has any form of, I think we've got a kind of a representation of the guidelines as opposed to the document itself.
No, we link to them from the
We
website.
actually link to the document itself.
The British Society of Haematology website is not closed to
Right.
BSH members. Anybody can link on it.
I just have a comment.
Cheryl.
Dr. Harrison, if you could comment on a guideline of why there's such a difference between European and North American doctors prescribing interferon for MPNs. Our experience in North America, Canada anyways, is that there is a hesitancy, a very big hesitancy in prescribing interferon, possibly because it's off-label. But why is there, and I mean, we have patients that comment on, the virtual Facebook pages and support pages and whatnot that they're on interferon, and when we ask doctors in Canada why patients are not able to go on interferon, and we see other patients going on it, then there's some controversy. So could you comment on that, why there's a differential in opinions?
Few comments. I think it's a bit like if you're a transplanter, you want to transplant. If you're not a transplanter, you don't want to transplant. Some of us might remember patients who've had a terrible time on interferon. Others of us might remember patients who are on a tiny dose of interferon and continue to be extremely well and very active. Yeah. So it might be the individual doctor's perspective. Many clinicians don't see many patients. In the context of young patients having interferon, many clinicians only have the experience of the older-fashioned formulations of interferon. Thinking about the CML field, we used to give extraordinarily high doses of interferon to our patients with CML. Many of the doctors treating MPN patients also treat CML patients and probably remember the terrible time they put their patients through with interferon. But I also want to point out to you the data that I showed you this morning about actually equipoise in terms of the data for interferon versus hydroxyurea. And I think it's probably okay, Mary Frances, to say that we just pretty much have decided in the UK to say there is no available data to distinguish between hydroxyurea and interferon, and an individual decision should be made for any patient. Part of the problem might be about reimbursement. I don't know how that works. In Canada, the drugs cost a lot. The difference is... Yeah, so interferon's around £15,000 a year, and hydroxyurea is about £15 a year for us. So.
Doesn't it seem a little slanted in the fact that Pegasus is a slow-acting drug and hydroxyurea is a fast-acting drug, and Pegasus takes maybe 2 years, maybe 3 years to take effect. And looking at a 1-year comparison, to me, doesn't seem like a valid comparison.
What effect do you mean?
The counts, how the patient feels, side effects.
So actually, the two studies showed that the patients achieved the blood counts control at the same rate after a year. And probably partly reflects the dosing that's used in the studies. In my practice, I tend to start low and go high for most patients, except if they've got an acute event when they progress. The data is immature, but there is no data, and this is the problem. And there is no right drug. You have to individualize it. And for me, I put both drugs in front of my patients, or for ET, I put all 3 drugs in front of the patient and try to guide them a little bit. But I think it's a huge shame that here we are in 2017, we've completed massive phase 3 randomized studies with JAK inhibitors, but we still don't know the basic question. Is it hydroxyurea or is it interferon? And that's partly because we have to do that. We don't have, pharma companies such as Novartis and Incyte don't own pegylated interferon, and we've had a huge difficulty in engaging with the companies that own those drugs.
When a patient comes in, do you give them that option if they're, been with the illness for several years?
Which option?
To choose which drug.
Of course, all my patients get the choice
Okay.
of which drug, but I'm in the fortunate position of actually, in my hospital, I can prescribe either drug. But I think my point in Canada was if it's not reimbursed, that might influence. I'm lucky in our health economy, I don't have to be limited by that. And for me, I would say to my patients, there are pros and cons of both drugs. Your quality of life might be a bit difficult initially on interferon, might not. And if you use hydroxyurea, you may store up potentially problems for yourself in the longer run.
Okay.
Peter, I think you had a point.
I just have certain problems to accept these guidelines. Same as it's being said, once you're 60, you have been a phlebotomy. After 60, you should take hydroxyurea. I had a long battle with my Dr. Besses, who wanted me also to take hydroxyurea after 60, and I managed to be the winner during 10 years. The reason why I'm saying this is nearly every PV customer is totally different. I was recently in a meeting in Switzerland with 10 PV patients, and everybody had a totally different story. So my question is, how can you make guidelines if nearly every patient has a different story? Every patient reacts in a different way. How is this being made?
So then your view is we should just tear them all up and be individual for every patient. Well, a guideline is a guideline. It's not a protocol. And actually, maybe that's where I should have started. A guideline is to guide. It is not to prescribe. It is not to say, thou shalt do this and thou shalt not do that. Every doctor needs to be aware of a guideline, and there is evidence behind the guideline. Okay, it's old evidence, but we all know that as we get older, we have an increased risk of vascular events, and that's the premise of the initial evaluation, which clearly showed that as you get older and as you exceed 60 years, your risk of a vascular event becomes higher. Now, some of my patients are super fit, and at 80 are fitter than other patients are at 50. And as a doctor, I need to know about the guidelines, but individualise that to my patient. I just have to inform my patient. As long as I know that they're educated and informed, they can make a decision. That's my view.
So basically agree that nearly every patient is different, has a different history.
Exactly. And I think every clinician in the room is probably well aware of that and takes that into account in their practice. But we still have to have some guidance, some basic idea of where are there changes in the journey of treatment.
Reinier?
Just a short remark. Doctors have their bias because of their own experience, but also patients and patient groups have their bias. You can read very nice stories about how interferon is doing patients well, but it certainly isn't true for every patient. So that's more or less a remark we should keep in mind. So be also on Facebook, and so you see now in patients, you see that some therapies are promoted, and be careful.
Yeah, I think that's something that you could perhaps discuss and debate, is that how do you achieve a balance in the discussion? So Maz, who's at the back of the room, works hard with the medical community in the UK to try to achieve a balance in terms of the discussion that happens on our online community. But there are groups that would say interferon's fabulous. A patient of mine recently, a young woman with ET, CALR mutation, she'd been on a CALR mutation website and was convinced that she had an 85% chance of becoming myelofibrotic in 3 years. Very difficult.
Beth?
You were saying about the new treatments when they come out, it's not reflected in the guidelines, so they're not as current. Do you think there's definite disparities where some doctors will be using the latest research to then guide their treatment, and then there's going to be some other patients that are missing out on that because the doctors will just follow the guidelines and not follow the new research that's coming out?
So a good guideline should have a sell-by date and should be regularly reviewed. And if you're a clinician following a guideline, you should be well aware of that limitation. Also, a good clinician will be up to date in terms of their clinical practice. But I think we all recognise that's incredibly hard if you're managing across the breadth of many, many diseases. So yes, I suppose there's a risk. There's probably a risk that I'm standing up here today and I've missed a more up-to-date guideline. But I think you have to believe that a decision is never made in an instant, that a decision between a doctor and a patient is made over the course of several conversations and should be regularly reviewed. So what I advise my patients and what we try to advise through the MPN community in the UK again is to find a doctor that you have a good relationship with and that you can trust.
One last comment to make regarding the guidelines. The NCCN just came out with a patient guidelines in the United States, and I think that it's excellent for newly diagnosed patients that don't know anything about any of the NPNs, and they start reading through a 80-page guide and learning about it rather than going online and being confused and led in the wrong direction. How do you feel about that?
I think that's excellent, and in fact we decided to put a section in our guidelines about what you should tell patients. Unfortunately, you can't the question is, how do the patients get that information? Do they get handed it by their clinician? Is that the suggestion with the NCCN? Because reaching every patient is really hard.
So that's a challenge. I mean, it's on my website. I know that the Research Foundation, it's on their website.
Good.
And several others, but it's not out there like it should be.
So they
Yeah.
might have gone to that, they might have gone and completely misinterpreted, like that young woman with ET did, some information from somewhere else, or got terrified and not looked at all. It's
Could you
difficult.
get to the hematologist somehow? It'd be great.
Yeah,
if you
so
could.
I think that's some practice sharing that you could do as a community. I mean, we, in 3 weeks' time, will have a clinician event where we will have lots of patient material. We try to, send out to all of our colleagues. We try to promulgate through the patient community. You can only do your best, though, I think.
Okay.
Excellent. Thank you very much. We're going to wrap this session up there. We have a coffee break now. I'd just like to thank once again Claire and Mary Frances and Rainier for their participation in the session.